welcome to another edition of the Osteopathic Lyceum podcast. Now this is going to act as an introduction primarily because the structure of this is going to be different than what I've done before and than many other things that would call themselves podcasts. Now this is primarily ideal to consume visually, so this will obviously be on YouTube and on Spotify, and to the degree that on Spotify you have access to the visual medium, because you're not just listening to the audio only, this will be available in multiple places. Now what this is from, or what follows this, is from a live workshop that I did where I was trying to show a few things. One, that the common sacral models, or models of sacral mechanics, or predictions of the models of sacral mechanics, may not necessarily hold as you would want them to hold. Also to show that you can generate essentially live experiments with major flaws because they're not properly controlled. There are multiple things that could influence the outcomes, and that the manner in which we apply some form of intervention we're controlling as best as we can. So lots of issues with how this runs, but it proves, or not necessarily proves, it gives some evidence that, at least very superficially, this all can be done. You can do proper testing, or close to proper testing, of osteopathic claims, osteopathic methods in live bodies. So this is possible. And what you're going to see is essentially a set of fairly consistent tests. There will be some times where I remove one of the tests because there was no positive finding, so we take it out. If there was a positive finding, we would have left it in. But we have a set of tests and a prediction. Now the primary prediction would be that wherever in the areas that we've tested that there is an identifiable problem, if we treat that area, there should be diffuse effects to the other areas. Now what we actually end up seeing, or if we were going to accept that, then no matter what we treated in the area of the test that where we had a finding, the other area should have improved. What we actually end up seeing, which would be able to be put out as another prediction, is that areas that move more within the human body will have more diffuse effects. Therefore, if you have an area that you also test that has less movement, it should have less diffuse effects when you intervene with it. So essentially we're looking at the lumbar column, the sacrum itself, as well as the hips. So the prediction that we end up gaining confidence in is that when you have areas that move more, they will have more diffuse effects. So treating the lumbar column should affect the sacrum to some degree and the hips to some degree. Treating the hips should affect the sacrum and the lumbar column, whereas treating the sacrum in and of itself as an individual unit, not in combination with anything else, which is why we treat short lever directly on structure in what follows, is that if we did a combined method, then there's too many confounders. So we treat short lever directly on the structure we're trying to intervene with. And what you'll see is that at least to some degree, there's agreement that treating the lumbar column changed the sacrum a little bit and the hips, and treating the hips changed the sacrum a little bit and the lumbar column, whereas treating the sacrum didn't really do much to the other structures. So what you're noting is increased confidence in the prediction that areas that move more will have more diffuse effects, and treating those areas will have more diffuse effects, or intervening with those areas. So we get this generally as an overview. Now if you're listening to this in an audio-only format, you'll still get the gist of it, but there may be some value in seeing it. And I will also note that the angles of the camera shots will not make these things as visible, but you do get some visual to understand this better. There would have been some camera angles that would have been more level with the test that would show more of what we're talking about, but at least we have some reason to believe that the people in the room agreed on what was claimed and what was found and what was seen. So please enjoy and consume the rest of what comes after this, rather. Okay, so what we're going to do is we're going to do a standing flexion test to identify the positive standing flexion test. Tuck your chin to your chest and start to roll forwards until I tell you to stop. Good, and stop. Okay, so ideally on the camera, you should see my right thumb slightly higher than my left thumb. Does everybody in the room agree with that except for you, because I'm testing you?
Yeah.
Yeah, we agree.
Cool, all right, come on back up. There you go. So we're going to do a seated flexion test to identify the positive side for the seated flexion test. So it'll be similar to the standing flexion test. Tuck your chin to your chest, roll forwards until I tell you to stop. Good, and stop. Okay. Would everybody agree that my right thumb is higher than my left thumb?
Yeah.
Yes.
Okay, we'll have you come on up and just relax. Okay, so we're just going to get a general test of the lumbar column with respect to side bending, so we understand which side may have some form of dysfunction. My hand is just at the base of the lumbar column as a visual reference. Okay, so we're going to have you bend to your left as comfortably as you can, and keep going. If you can go more, fantastic. Then we'll have you go to your right, and then come back to the middle. Now, would everybody agree that he bent easier to his left than to his right?
Yes.
Okay, there we go. So essentially what we're going to say is globally the left lumbar column, the lumbar column is globally side bent to the left. It has a preference for motion to the left. So now we're going to do several tests in series. Okay, so what we're going to do is we're just going to have the patient take a deep breath to check the lumbar column. Take a deep breath. And let it out. Okay, then we're just going to come a little bit closer in the frame, so I'm actually going to use a little bit more palpation, because what I'm going to do is I'm going to pay attention to my hands and what moves and what doesn't. Take a deep breath. And let it out. Okay, so it's somewhat subtle. Would everybody agree that the right side of his vertebral column pushed my hands up higher? Take a deep breath. And let it out. Would everybody agree that this side moved more?
Yes.
Okay, fair enough. And what that essentially suggests is that that matches our left side bending finding. That left side bending means that this is probably going to move a little bit less. We would call that more or less an approximation of the facets, and then this is going to move back a little bit more. But what we get is a differential finding one side to the other. Okay, so now what we're going to do is we're going to do a general sacral test. We're going to do a Sphinx test. Okay, so we're going to identify where the sacrum is generally. We're going to come more or less to the top. Okay, now my thumbs are a little funny, but if I push in, right, you'll see my right thumb goes deep, my left thumb doesn't. Would everybody agree on that?
Yeah.
Yeah.
Okay, cool. We'll have you come up onto your elbows, and you're going to extend. Okay, now, right thumb goes down, left thumb, would you agree that the left thumb goes down a little bit more in extension? Okay, so we have a change one to the other. But generally speaking, the right side is deep, the left side is a little bit more superficial. Fair enough? Okay, we'll have you drop back down. Okay, and now what we're going to do, so we have lumbar finding, ilium finding, so your positive standing flexion and seated flexion test, both on the right side's deep. Then we have the bilateral hip test, okay? And we're just going to see which hip has more restriction. Would everybody agree that the left hip, at least in this test, has more restriction?
Yeah.
Okay? Sounds fair. Okay, so we have a series of findings. Now what we're going to do on purpose is we're going to treat the sacrum and retest the other stuff. Because if the sacrum is as important as people claim, increasing its motion should alter what is happening with the other stuff. Now, to try to make a reasonable claim, I can't use a long lever approach, can't use the lumbar column, I can't use the hip. To do this, I have to treat the sacrum itself. So I will add in just a simple overpressure test. Now I'm going to push on the left side and push on the right side. Now, because I'm biased on the table, this isn't perfect, but when I push on the right side, just pay attention to my hand, or sorry, the left side, I push on the left side, you see what that motion quality is like. And when I push on the right side, would you agree that I get more yield? Right, left side, right side. Would you agree there's more yield on the right side? Okay, so what I'm going to do is I'm going to push and just hold for overpressure on the left side. So my hand's going to obscure it because I want to be mechanically efficient. And I'm just going to wait. Now as he breathes, we're going to have, just don't breathe normal, don't worry about it, don't overdo it. We just wait, all right? So we can call this myofascial release. Some people would call this inhibition. Call it whatever you want. But I'm trying to be as specific to the sacrum as I can to see what types of changes I have. Right, and we just wait and we wait and we wait. How do we know we're done? We don't actually know we're done. Sometimes you just wait until you want to give up and run away, which happens to me relatively fast with some types of treatment. Okay. Now, push into the right side. There was normal yield. Would you agree there's some change in the yield there?
Yeah.
Yes.
Okay. We're going to do a little bit more so that we're honest. Right? So what I'm going to do is as I push in, the higher portion of the sacrum is moving a little bit better. The lower portion, I feel a difference here. So I'm going to work there for a moment. And again, the reason I'm specifically working short lever on the sacrum is because I want to remove confounding factors. If I use the leg as a lever, then the claim couldn't be made that I treated the sacrum to change the other stuff. Right? Good. Okay, so now, left side, right side. Would you say that visually the yield looks a little bit more similar side to side?
Yeah.
Okay, as long as we have some agreement. Now what we're going to do is we're going to go to our lumbar test. So our assumption is that the lumbar should have changed in a notable enough way, and we're going to do this as a series of tests, okay? So, take a deep breath for me, and let it out. Okay. Would you agree that that's leveled out a little bit? Take another deep breath and just watch my hand. And let it out. Okay.
Yes.
Yeah.
So it's leveled out a bit. Would you say that this is still moving higher than this? Mm-hmm. Okay, so we would agree that there's at least on this test some change. Yeah. So we treat the sacrum and there's some change. Absolutely no problem, which is what we want to see. We're going to do our sphinx test. Okay. Now you see here, that's still the deep side, this is still the high side, okay? Would you say that based on, compared to the first test, this is moving a little bit better when I do that? Okay, come up into sphinx. Okay. Now there, when he's up into sphinx, that's a tiny bit better. Okay, a tiny bit better, comparatively. Come on back down. We're going to go in, so ideally the left hip should have leveled out. It should be much more similar to the right hip. Okay, did we see much change in the hip? Or does the left hip still look more restricted?
Still more restricted.
Still more restricted. So, at least with respect, so we got what seems like some change in the sacrum, what seems like a minor change in the lumbar column, no change in the hip. Agreed upon? Okay, we'll have you sit up, my friend, and face towards the wall you were before. Okay, so now we're going to come over the shoulder. So now we're going to do our side bending test. So he was side bending better to the left. So what we want to see is a change. We want to see him side bending better to the right. So side bend to the left so that we have our start. Okay, that seems somewhat similar. And then side bend to the right. Is there much change to that? Because I would say that there is not much change to that. Would everybody agree with that?
I would.
Okay, so now we do our seated flexion test. Okay, so we assume that the seated flexion test should change. Drop your chin to your chest and roll forwards. Here and stop. Okay, does that change a little bit?
Yeah.
Yeah.
A little bit, but is it gone?
No.
It's not gone, okay? So we come up. So we'll have you swing over and stand facing over there. All right. There you go, my friend. Coming back towards me a little bit. Okay, so now we're going to do our standing flexion test. I'm going to try to pull the shirt tight. Okay, drop your chin to your chest, roll forwards. Good, and stop. Did that change?
Not really.
Nope, not really. Okay, so there we go. So we have some change in the sacrum, not really much change in the lumbar column, and not really much change in the hip. So at least on that, we note that when we do something to the sacrum, and some people may criticize and say it wasn't enough to the sacrum or wasn't the right treatment, totally fine, acceptable. But we can say that we tried to treat the sacrum for some period of time, we got some change in the sacrum, and not much diffuse change. Okay, we can stop forward. Okay, so what we're going to establish first is our standing flexion test. So we're going to have you tuck your chin to your chest and roll forwards until I tell you to stop. Good, and stop. Okay, so would everybody agree that my right thumb is high, my left thumb hasn't moved?
Yeah.
Okay, okay. All right, so what we're going to do is we're going to have you grab a seat on the table. Okay, so we're going to do our seated flexion test now. So drop your chin to your chest and roll forwards until I tell you to stop. Good, and let it stop. Would everybody agree that my right thumb is somewhat higher?
Yep.
My left thumb hasn't really gone anywhere. Okay, come on back up. Okay, so now we're just going to establish our general lumbar findings. So my hand is here for visual reference. If you bend to your left. Okie dokie, good, and bend to your right. Good. Now, is there a notable difference between them as far as actually, I'm going to redo this just with a better frame. Okay, so have you bend to your left? So if you look at the lumbar column, there we go. So we're not paying attention to the stuff on top. Good, and then bend to the right. There you go. Now would everybody agree that the lumbar region bends better to the left than to the right? Would you agree with that? It's okay, just get a slightly better angle.
Yeah.
It's okay.
Sure.
Yeah, that's fine. And just squat down so that we can keep the shot. Okay, so again, you see some vertical line here. Okay, bend to the left. Good, so we're looking in here. Good, and then we'll bend to the right. There you go. As far as deviation in the coronal plane, would you agree that there's more deviation to the left than there is to the right?
Yes.
Okay, so we have a side bending left finding. Okay, we'll have you on your stomach. There we go. So we'll have our general lumbar test here, and what I'm going to do just for efficiency, I'm not going to do the full vertebral column test. I'm just going to do respiration with my hands generally on the lumbar column. Okay. Take a deep breath for me. And let it out. Okay. There does not seem to be a notable difference in that particular test. Would everybody agree that that looks relatively stable and level?
Yes.
Okay, so we're comfortable. So this test is now going to be removed from our post-test because this test is relatively clean. So we're not going to use that with this particular individual in our post-test because there should be no change because it is already moving reasonably well. So now we're going to check in through the sacrum. Okay, so we're going to go with the Sphinx test. Okay, so first, in a comparative sense, would you say that my right thumb goes deeper than my left thumb here?
Yes.
Okay, good. Have you come up on your hands and you're going to go into full extension? Good. Would everybody agree that those are about the same in extension? Okay, there we go. And come on down. Okay, so we have the right side deep, but then on extension, the left side levels out and they're about the same. Okay. Now what we're going to do is our general hip test, just to identify which hip is more restricted. Would everybody agree? In this case, it's the left hip. Okay, so the left hip is more restricted. Now we're going to, because this patient doesn't really show anything in prone, in the lumbar column, we're going to choose to treat the left hip. But first I'm going to just do a general overpressure test on the sacrum. So when I push on the left side, it moves okay. When I push on the right side, would everybody agree that's not notably different when I do that overpressure test? There's some minor difference, but it's not really notable, okay? So what we're going to do is we're going to treat specifically the left hip and then see what happens with the tests. So the test that will show us some difference with the sacrum will actually be when she's fully prone and we just do general, the initial portion of the Sphinx test, not the full Sphinx test, because the full Sphinx test already has it level out. So we're just going to find it there. And then our lumbar test will be in seated. And we're also going to retest our standing and seated flexion tests to see if they change. Okay. So at least now what we can do is we're going to treat the hip. We're going to do it soft tissue and short lever so that we're not necessarily reefing on the sacrum. So we're going to try to isolate the treatment to the hip itself. So we're just going to go around the trochanter and identify where we have higher tone tissue. Right. Now, as the patient, would you agree that this is a place where you notice a difference in the tissue when I push on it?
Yes.
Okay. All right, so the reason I'm asking so many questions of everybody in the room is to try to note that there are ways in which palpation or really resistance to overpressure or yield to pressure tests have some value that the practitioner can identify where it doesn't yield well, and the patient will often agree. The patient's sensations may be variable, but there's some value here. So we're just going over pressure to this soft tissue or yield Now again, people can call this myofascial release, you can call it short lever myofascial release, you can call it inhibition. The thing that you call it doesn't necessarily matter as long as we can agree that we're not treating multiple things on purpose. We're trying to do a soft tissue release of the left hip itself. And the way that we'll know that it worked is that the left or the bilateral hip test should show some differences. And we're specifically doing an internal rotation, so that's where we expect the change. And one of the interesting things, if you pay attention, how I'm not necessarily trying to push deeper and deeper as this works, but if you notice when my hand comes out, there will be a decent amount of play. So as the patient breathes, there's always movement in relation to the table. So you just take your time and let it roll, and you don't overbear on it, you just pay attention. So basically, there's no point where the patient should flinch or jump. You just follow. So as I take my hand out, you'll see how far that went, right? Now we do a retest and a comparison. Now, would you say that there's some resistance to the overpressure here as the patient? Mm-hmm. Okay. So again, we're just working around the trochanter. Now the assumption is that with respect to the ability of the hip to rotate generally, but specifically with internal rotation, you should be able to identify structures or soft tissues around the trochanter that would have some resistance to pressure, or they would not yield well to pressure. Right, and again, this is going to be the same thing. So you won't see me taking any slack up in an obvious way, but you'll notice that when I take my hand out, there will be a lot of travel. Now you'll be able to see the patient breathing. All your patients should definitely keep breathing the whole time. Shouldn't have to coach it, but if they stop breathing in either direction, we all have a problem. There we go. So now when I take this out, you'll see that travel, right? There we go. Now as the patient, would you say that that's changed?
Yes.
Okay, fair enough. So now we're going to test, and ideally the hips will have evened out to some degree. Now would everybody agree that those have evened out?
Yes.
Right? There's change in the restriction, okay? So now we're going to come through here, come through here. Now I may not be in the exact same place, but does that look more like even motion or even distance? All right, it's not perfect. I may not be in the exact same place, and I'm admitting that, but that looks more even.
It does.
Okay, good. Now we're going to have you come up to seated and face over this side where you were. Okay, so we'll have you swing back over my shoulder so that the camera's in a similar spot. Okay, and we'll take a similar position because I had a hand at the bottom and a hand at the top of the general lumbar region. Okay, right. Now we'll have you bend your left. Okay. Would everybody agree that she's more or less moving farther there now?
She is.
Okay, and then we'll have you bend to your right. And ideally, this should show some change. Now that's not perfect, but would you say that she's moving better to the right than she was previously?
Yeah.
Okay, so we didn't touch the lumbar column, we touched the hip. So we got some change in the sacrum, not perfectly notable, because it wasn't necessarily bad. We got some change in the hip, and we've got some change in the lumbar. So treating the hip has diffuse effects. Would everybody agree with that?
Yes.
Okay, so now our assumption is, well, not necessarily our assumption. The thing that we need to test is our seated flexion. Okay, right? Drop your chin to your chest and roll forward as best you can. Good, and let that rope down and stay there. Would everybody agree that my thumbs are somewhat level? Mm-hmm. Okay, good. Now come on and back over here to where you were standing. So you just swing over and stand on up, please. Thank you. There we go. Good. Drop your chin to your chest and roll forwards. There you go. And my thumbs are somewhat in the same spot. They haven't really moved much. There you go. So we have treating the hip, having diffuse change on the lumbar column, the seated flexion test, the standing flexion test, at least to some degree on the sacrum. But that's not as clear, but again, the sacrum doesn't move that much. So the hip moves a lot. We treat the hip without treating other things. We have diffuse change in varying areas. Okay, so we're going to establish our standing flexion test. We'll have you drop your chin to your chest and roll forward until I tell you to stop. Good, and stop. Would everybody agree that my right thumb is slightly higher than my left thumb?
Yeah.
Not major, but it's slightly higher. Okay, come on up. Okay, we'll have you sit on the table. Okay, so come back over here, my friend. Okay. Okay. Now my thumbs are relatively level. Are my thumbs visible on the camera?
Mm-hmm.
If you drop your chin to your chest and roll forth until I tell you to stop. Okay, and stop. Would everybody agree that my right thumb went up slightly?
Yeah.
Okie dokie. Come on back up. So we have our positive seated and standing flexion test on the right. Okay, so we're going to do our general lumbar side bending test. Okay, so we'll have you side bend to your left as comfortably as you can. Great. And then side bend to the right. Good. And would everybody agree the lumbar column deviates more to the left than to the right?
Yeah.
Okay, so we have side bending left. Okay, we'll have you on your stomach for a moment. Okay, over here. Okay. So we're just going to do our general lumbar respiration test. Now, if this test doesn't necessarily show us something uneven, well, we already have our lumbar deviation to the left. Okay, so what we're going to do is just be in the general lumbar region with our hands. Try to be somewhat even, although I'm on one side. We're going to have the patient take a deep breath and let it out. Okay, now would everybody agree on that test? The lumbar column generally didn't move much. Okay, so we don't have a finding on one side or the other. We have a general lumbar finding of when this particular patient's in prone, the lumbars don't move much. Okay, so now we're going to check through the sacrum. Okay. Now would everybody agree that in a comparative sense there's more travel on the right side than on the left? Okay, fair enough. Okay, we'll have you come on up into Sphinx. Now did everybody see the left thumb go down? Mm-hmm. Okay, now travel, does it look more even when he's in Sphinx? Okay, fair enough. So we have it leveling out. Okay, we'll have you come on down, right? Now we don't have to do a sacral overpressure test because we already identified that the right side is deep, at least for the purposes of what we're trying to identify, because what we're going to do with this particular individual is we're going to treat the lumbar column specifically on the left side, and then we're going to see what that does to the sacrum, because we already have a positive identification of sacral asymmetry, and we're going to see what it does to the hip, so we have to do our hip test. Okay, so what we want to be able to see on the camera is the difference in how the hips move. On this particular patient, they move quite well, but, so we'll pay as close attention because they move generally well. Okay, so we get to the end, or close to the end. I can give this a little bit more and that not much. Would we agree that the right hip is slightly more restricted than the left? Mm-hmm. Okay, fair enough. So now we're going to treat the lumbar column and try to only treat the lumbar column, so we're going to go short lever to the soft tissues on the left side of the lumbar column, because the left side, based on our seated side bending test, is a side that liked to be short, did not like to lengthen as much. So we're assuming, or at least making an educated guess, that these tissues are shortened. Okay, so we're going to treat through the left side of the lumbar column. And now if we're correct about this, what we should ideally see is change in the prone respiration test. So the lumbar column should move slightly more when he takes a deep breath when we're done. And the right hip should have a little bit more play. So they both move quite well in internal rotation, but the right hip is slightly more restricted. And then we should also see, if we're correct about this, a change in the depth. So the right side should be somewhat similar, but the left side should have more play. Right, now the reason we're going short lever to the soft tissues of the left side of the lumbar column is because we don't want to go long lever and involve other confounding structures. So we're trying to generally see if the prediction holds. And the primary prediction is that things that move a bunch will have a more diffuse effect than things that don't move all that much. So if we just drew to the sacrum, we would expect that there would be some change in other things, but maybe not as diffuse a change on account of the fact that the sacrum just doesn't move much, whereas the lumbar column and the hips move comparatively more. All right, now each individual being different, you will have a variety of findings, you'll have a range of findings. Not everybody will be exactly the same. This is why we want to do this to as many people as we can. Now you're going to do this in your actual practice, right? So when you're actually treating the general public, you are running experiments all the time. You may not see them as such, but you are running them all the time. If you're an osteopathic practitioner, what you're guided by is the barrier concept. So you're not trying to, or you're trying to purposely avoid large responses in the patient. You want the patient to essentially minimally respond, right? You don't want them to jump, you don't want them to feel particularly uncomfortable, even when you're working in areas that may be uncomfortable to them as far as sensation is concerned. So it's tender or things like that.
but you don't want to make them jump. So you see all that play when I came out? Right, now we're going to move up just a little bit because we want to generally get the lumbar column. Now the size of my hand versus the size of the particular individual is always going to be variable. So on somebody who is shorter than this particular individual, I may only need to do it once because I would cover more. But with him, we need to go slightly farther. Right, so you won't see my hand moving, you won't see me generating obvious overpressure, but when I take the hand out, you will see a notable change. Or, well, you'll see the travel when I come out. Now, the reason that works is because as he breathes, everything's moving in relation to the table. My hand is relatively still, so I get something every time he breathes without trying to actively do it. All right, now when I come out, you'll see how much that moves. Right? Okay, so now we're going to go through our retests. We're going to retest the lumbar column first. So we all agree that it didn't move particularly well, generally speaking. Okay, take a deep breath for me. And let it out. Would we all agree that that moves slightly better? Right? Not perfectly, but slightly. Okay, we're going to come into the sacrum. So we're going to have you come back down here so you can see this. Now it may not be in the exact same spot. There's the play there. Would we say that that's leveled out mildly? Not great, mildly. Now come up in the Sphinx. Okay, now the Sphinx. Now when he's in Sphinx, does that seem better than it did? Okay, there we go, come on down. Okay, so now we're going to, at least based on our prediction, believe that the right hip will have changed to some degree. So again, he had great external rotation. Right, so remember I got that end play. Would we agree that that's mildly better, even though it wasn't bad before?
Yeah.
Okay, so we're gonna have you sit up. Okay. So we're going to go to our lumbar side bending test. Try to have my hands somewhat similar to the exact way I had it before. We'll have you bend to your left because it was already good. Okay, does everybody agree he's going slightly farther now? Okay, bend to the right. Does that look like an improvement? Okie dokie. So we have improvement. We treat the lumbar column. We expect the lumbar column should improve. There's some improvement to the hip, although the hip wasn't bad. Now we're believing that our seated and standing flexion tests should change at least to some degree. Okay. Tuck your chin to your chest and roll forwards. Good. And stop. Now, does everybody agree both of my thumbs went up? Okay, but not in an uneven fashion. Okay, come on up. So I'll have you swing over here and stand on up. Okay, tuck your chin to your chest and roll forwards. Good, and stop. Everybody agree both my thumbs went up mildly, but even now.
Yeah.
Okay, there we go. So now we have treating the lumbar column, having a diffuse change on our standing and seated flexion test, to some degree on the sacrum, obviously to the lumbar column and on the hip. So things that move more have a diffuse effect when you treat them. There you go, you can stop.